In this video, we're going to present a standardized technique for port positioning in laparoscopic colonic resections. After a brief introduction, we're going to discuss port ergonomics, and then we're going to proceed in a detailed description of port positioning for right, left, and subtotal colectomies. Laparoscopic colorectal surgery offers distinct advantages to patients when compared to open surgery. On the other hand, it is proven to be technically and physically demanding. It often requires four-quadrant involvement, has limitations in the manipulation and visualization of tissues, demands long learning curves, and can cause considerable physical discomfort to the surgeon. Inefficient walking postures have proven not only to cause that physical discomfort, but also negatively affect surgical performance. Although minimal access approaches have been described in the literature for nearly all abdominal surgical procedures, there are very few authors that have investigated trocar placement in relation to optimal ergonomics and related technical considerations. This is why port placement and operating room setup have high variability and usually follow individual surgeon preferences. This is why port ergonomics based on the current literature are going to be discussed next. We're going to introduce concepts as manipulation and azimuth angles, study key elements of postural ergonomy, and point out important considerations. Manipulation angle is called the angle between two working ports. It was first introduced by Hanna in his research for optimal port placement when executing a difficult task, as intracorporeal endoscopic knotting. He found that a 60-degree angle had a statistically significant shorter execution time and highest performance quality score. A 15-degree variation was tolerated, but beyond that, a negative effect on the surgical task was observed. Azimuth angle is called the angle between an instrument port and the optical port. Again, Hanna, in his research, found that when these angles are equal or nearly equal, there was a faster execution time on the surgical task at hand, here being intracorporeal knotting. Although unequal angles had a negative impact on execution times, there was no statistically significant difference found on the quality of the knot. As mentioned earlier in this video, laparoscopic colorectal surgery can be arduous. Often surgeons have to move their hands and arms in awkward positions and have their heads turned for hours at a time to the direction of the laparoscopic monitors. This can provoke substantial physical strain and subsequently affect performance. Minimal access surgery differs from conventional open surgery in that it uses an image display system as the visual interface between the surgeon and the operating field. Often the monitor is placed in awkward positions in crowded operating rooms, and apart from causing discomfort to the surgeon's cervical spine, can also affect performance, as we will see next. The principle of the motor visual axis stands for the alignment of the visual interface, in this case the monitor, with the hands and instruments of the surgeon performing a laparoscopic task. It has been proven that frontal view direction is superior to side views, indifferent if that side view is left or right, when a surgical task is performed, with statistically significant shorter execution times and quality performance scores. Also, when in frontal view, hand-level, gaze-down viewing resulted again in shorter times and increased performance scores when compared with the eye-level frontal view alone. Next, we would like to point out some important considerations that help prevent risk and increase efficiency. When planning a port placement strategy, it is useful to know that 5mm ports, when compared with larger ports, have a statistically significant less postoperatorial pain score, port-related complications, and patient satisfaction as far as cosmesis is concerned. Also, Ports placed on the upper abdomen, no matter what the size, are significantly more painful than those placed in the lower quadrants. We highly recommend the use of local anesthetic infiltration prior to port insertion, since it has been shown to cause less pain in the immediate postoperatory care. Finally, we recommend insertion using the rapid twist mild push technique, meaning that we rapidly twist the port trocar while only pushing gently, always under direct vision and in a 90-degree angle to the abdominal wall. And no matter what the pathology, we always use a wound protector in our extraction sites. Port setup for ileocecal resections will be described next. We insert a 10 mm port in the inferior part of the umbilicus, and we use two 5 mm operating ports for our resection. The first one is placed 2 finger breadths medial to the superior anterior iliac spine in the left iliac fossa, and the second one just above the pubis. Since in the majority of cases ileocecal resections are done for Crohn's disease, we use the midline as an extraction site, preferring to leave abdominal areas that could be used in the future as stoma sites unscarred. For right hemicolectomies, after insertion of the optical port, we use a 10 mm port placed 2 finger breadths medially to the left superior anterior iliac spine. This port will be used for the clipping of the mesocolic vessels. We then insert 2 5 mm ports, which will be used alternatively as working operating ports or assistant ports, depending on the site of dissection. One is placed suprapubically and the other on the epigastrium just to the left of the midline in order to facilitate dissection and exposure. Extraction is done through a midline or right flank incision, depending on the pathology. Port placement for left hemicolectomies and anterior resections start as all previously described resections with a 10 mm optical port at the umbilicus. A 12 mm port is placed 2 finger breadths medially and 2 finger breadths superiorly to the anterior iliac spine. This port is placed in this position in order to avoid hitting the pelvic brim when dissecting the lateral right part of the high rectum. It is a 12 mm port in order to accommodate the endoscopic stapler needed for the resection. An operating 5 mm port is then placed in the right upper quadrant, just medial and with a minimum distance of 1 adult fist to our 12 mm port. This is done in order to avoid instrument conflict when dissecting into the pelvis, when optimal manipulation angles are lost. Finally, we place an assistant 5 mm port in the left flank. We prefer a midline or left flank extraction for the specimen, using always a wound protector. We're going to describe 2 different setups for subtotal colectomies. In the first, we use 4 5 mm ports. First one is placed 2 finger breadths medially and 2 finger breadths superiorly to the right superior anterior iliac spine in order to avoid hitting the pelvic brim when dissecting the right lateral part of the rectum. Another 5 mm port is placed in the right upper quadrant, just medial to the first one, in order to avoid instrument conflict when manipulation angles are lost in the pelvic dissection. Another 2 5 mm ports are used, one placed on the left iliac fossa and the other one on the subxiphoid area. They will alternate from assistant to operating ports depending on the site of dissection. Finally, a 12 mm port suprapubically will accommodate the stapler and the vascular clips for the right, left, and middle colic vessels. It will also be an operating port during the right-sided dissections. In the second setup, which we find easier for the surgeon, a 12 mm port is placed in the right iliac fossa for stapling and clipping of the left mesocolic vessels, a 10 mm port in the left iliac fossa for the clipping of the right and middle mesocolic vessels, and another 3 5 mm ports in the positions described before. Always, we try to have a distance of at least one adult fist between ports in order to avoid instrument conflict when manipulation angles become too acute. Extraction is done through a fan and steel incision. In this video, we try to provide a strategy guide for port placement as far as different kinds of laparoscopic colectomies are concerned, based on the current literature. Our goal is to facilitate the surgeon, improve laparoscopic performance, and avoid unnecessary fatigue for the surgical team.